So great to see everybody here, kind of from all over the place, as I said. And I want to introduce Dr. Leon Knight, and we're going to go over today methods when it comes to ACL rehabilitation as well as return to sport. I think it's obviously a super interesting topic. A lot of, I shouldn't say controversy, but certainly conversation to be had, and looking forward to it. So Dr. Leon Knight's the owner of the Performance Doc Rehab and Sports Physical Therapy Center in Charlotte, North Carolina. He's an orthopedic and sports physical therapist who works with high school, collegiate, and professional athletes, specializing in sports-specific rehab with performance training. He describes his approach as practical and performance-based, and I think that's really what we'll dive into today. And Dr. Knight earned his doctorate in physical therapy from New York Medical College and his Bachelor of Science from Elon University. So appreciate everybody being here. I'll turn it over to Dr. Knight. We'll start it
Alex,
up.
thank you. First and foremost, I want to thank you and Kinvent as well for hosting this webinar and give me the opportunity to work with you guys and just share knowledge and continue to explore with the data and information that we have and continue to learn when it comes to ACL rehab, right? There's no right way to do things. It's just we're always trying to figure out a better way to do things, right? As information comes in. So looking forward to sharing some things I've been exploring with recently with my ACL patients. And I want to get feedback from you guys as well as Alex as well. During the whole presentation, you'll see our ideas mesh. Some are different, but ultimately you'll see that the common goal is for us to find the best way to return our athletes back to what they love to do with minimal re-tear risk, right? And make them better and stronger for their future in regards to their sport. So what as far as the presentation go, I want to make sure that everyone feels comfortable asking questions through the chat as we go along. If something's not clear, feel free to reach out through chat and let us know, and we're more than happy to stop and answer those questions. And then we'll also have a question and Q&A at the end of the presentation. But ultimately, as you guys have signed up for, you see is ACL rehabilitation, clinical versus practical methodologies. And I'll go more into what those are. So without further ado, let's get started. All right. So the way I look at this, right, clinical phases versus practical phases. If I was to rename them, it would be time-based, which is clinical phases, and practical phases, which is almost performance-based, right? So one is based on where are they in regards to time after ACL surgery. And then the other one is like, what can they do? What have they demonstrated capabilities? What kind of capabilities have they demonstrated? And that actually gives you the information needed to know if you need to proceed or not. So my phases, what I've been working with recently is protection, tolerance, capacity, and return to sport. So I keep it very simple, right? Protection is, for the most part, the first 6 weeks, right? And so we really are trying to minimize swelling. We are trying to gain range of motion, focus on quad activation early, and then we are going to make sure that they're safe in regards to ambulating and getting around and so forth. So if they have to lock out the brace because they don't have any quad activation, or if they do have quad activation, then you don't necessarily have to lock out the brace. Like it's very based on individual as opposed to where they are in phase in their where they are post-op in terms of time. Tolerance is going to be more about, okay, they're outside of that protection phase, so we don't have to protect the graft per se, or there's not so much swelling where they are limited to what they can do in terms of loading the tendon, loading the muscle, loading the quad, and so forth. So we look at now, okay, let's start to bring in different things, such as can they walk without a brace, right? Or if they should be able to walk without a brace by then. Or can they do a straight leg raise? 30. I usually go 30 in order to be able to move on from a certain phase, that protection phase. I want them to have that without a lag, right? And then I want them to walk without any deviation. So it's just really functional movements. Can they do a body weight squat? Symmetrical. Can they go up and down stairs? So my tolerance phase is, can they tolerate these things, and can they do them without compensation? So that's pretty much tolerance phase. In order to pass tolerance, you have to pass tolerance phase in order to start jogging, right? And so there's a test that we do. There's multiple tests that we do throughout tolerance phase in order to be able to start jogging. Capacity phase is just building up as much strength as possible with your compound movements, as well as with the emphasis on still building up the quad strength. So that's when you see people really doing a lot more of the weighted lunges, the loaded squats, deadlifting, like really trying to get strong as possible while starting to make sure they are improving their ability to jog, sprint, right? Now you're trying to eliminate deviations after they've been cleared from the tolerance phase to start jogging and running. And then in order to leave capacity phase, they are, they're starting to, they have to lift. I have a couple different tests, but when they pass the capacity phase, that means they've demonstrated a certain amount of competency in terms of running, stopping, accelerating, decelerating, and then they are strong enough through another number of tests to start cutting. So basically look at it like they pass tolerance phase in order to start cutting, start running, or jogging, I should say. They pass capacity phase in order to start cutting. And then return to sport phase is more your sport specific movements, a lot of change of direction, those things. Still working on building strength, but now you're trying to decrease the amount of asymmetry from left to right. And you do that by more the limb symmetry index testing that I do, single leg hop test, triple hop test at the end of return to sport in order to be able to return to sport. So that's when we start doing a lot more of the like force plate, the force plates, using those different tests in terms of how they're landing, time of stabilization, depth jumps, just regular jumps, single leg hops, all those things on the force plates as well, in order to see what type of force and what they're able to generate from left to right, and where does that stand in terms of their limb symmetry. So that's kind of what the practical phases are. I know we'll go into more detail, but just want to give you like an overview, and I'm sure Alex may have some questions as he uses more of the clinical, the time-based model. So
you ready to get into it now? So yeah, so I think, you know, as myself and many of us, and perhaps yourself, sort of, you know, how we grew up as physical therapists, right? Is you get a protocol from the physician or from your clinic manager, or, you know, kind of more experienced clinicians, and you look at it from a time-based perspective, right? And so I think not just the fact that there are 4 phases in that practical approach, and maybe more on the other side, but really that the tolerance phase goes everything from that protected motion all the way to clearing them to begin dynamic movement. So there's a lot of stuff going on in there. So, you know, do you feel like you apply, you know, like 0 to 2 weeks, 2 to 4 weeks, probably that protection phase,
Yeah.
I'm guessing, 4 to 8, you know, maybe 4 to 10 even is sort of the tolerance, and then 12, you know, 10 to 14 is sort of that capacity, and so on. Like, do you look at it? Do you apply the time stamps to it, or do you really look at it as, look, these are things you have to pass, whether it takes you, you know, 4 weeks or it takes you 6 or 8 or 9 weeks, and you have to do it.
Right. So I think when I came up with these phases, or when I was kind of, so I've looked at a number of different protocols, right? And then started looking at like healing times and all those things. And then based on some of the experience and things that I've seen in the clinic, I was like, you know, let's be performance based. Why are we just still only time based, right? And so I've noticed that a lot of there's usually people who are further along. So I felt bad holding them back, saying, hey, you know, it's not 6 weeks yet, right? It's not 8 weeks yet. It's not 12 weeks yet. And so I started trying to figure out what are some tests that give me confidence that they are able to move to the next phase. So when you ask me about like tolerance phase, you're right. It is a long period. So almost think about it as from, if I was to give you weeks, I would say from 6 weeks to 14 weeks, right? For the most.
Yeah, and I think it's, once you've been in it for a bit, it's easier to sort of like be comfortable with saying, yeah, it's, it's gray, right? But there's people, including myself, years ago, right? You're sitting there with a pen, okay, 6 to 14, got it. I'm gonna write that down, right? So,
Right. Okay.
but here's the other side of it, right? To play devil's advocate, what about that high school kid that comes in and crushes it, and they're 4 weeks out, and they have great motion, and they have great apparent movement? And we'll get into this, right? But what do you say to them? They're saying, I can jump on 2 legs at 4 weeks, right? Like my phase, your phase, they're probably still protection, right? Because they are so fresh out of surgery. How do you tell them, if they're looking at your phases saying, well, why not? You said I can do it if I have X, Y, and Z, right? Are there built, and we'll go into this later, but are there built-in sort of fail safes to say, yeah, you can squat and you can probably jump, but you can't do this, because there's always something that we can sort of weed out to hold them back, to hold back that overachiever that actually does look pretty good.
I mean, it's interesting. I'm thinking of one patient right now that I currently have who is 4, maybe going on 5 weeks. She has 130 degrees of range of motion bending, -2 degrees extension, was able to do 30 straight leg raises without lag. Can do a step down, with 2 risers, one time, but clean. Body weight squat still about right above parallel, symmetrical. But in order to start doing the jumping that you're talking about, there are checks and balances. I like to see them be able to do 15 straight lateral step downs in a row, right? No compensation, no hip drop. Usually really bending at the knee and showing control. I like for them to be able to do 15 forward step downs as well, 25 single leg squats.
Well, hold on. Let me interrupt you. We got slides for this, so let's not give people overload. Why don't we go to our first poll, just see what people are sort of thinking. So we'll put up our next poll of just methodology wise, clinical, practical, mix of both. What are sort of people out there? What are you using? Not based on this discussion, what you think you should use, but what do you actually use? This is anonymous.
I gotcha.
Of course, everyone's not mix of both.
I think it's a great topic and a great conversation to have, right? Like, there's no wrong way to do it, right? I think it's
right. People get better.
That's right, and it's an individualized approach, right? So a lot of times, I get a chance to work with athletes who heal faster, can tolerate more pain early, right? And they're not nervous of the unknown because they are comfortable being uncomfortable already, as opposed to a general population patient that's very nervous, think they're going to break something, they're fragile, they move slower. So I can't move both of them along the same way because they have different end goals.
Yeah, so I think mix of both. It sounds like most people kind of are in that intermediate, in between kind of phase. So yeah, let's get into a little bit more. We'll chat about as we get.
All right, so protection phase, a little bit more detail, kind of, right? Like you can see that's very. It seems so loose. You guys make me look like I'm just just freewheeling, right? But ultimately, I do have some precautions, which is, just I'm trying to minimize the swelling, right? I think that's very big. And then also the strain on the graft, right? The surgeon's not going to like me if I stress the graft too early. And I believe in that. Like, no, I don't want to undo or weaken anything that was done. So those are our precautions. And then in terms of focus, I keep it very simple. And I think with the practical phase, it almost is like simple to a degree. When we keep going through it, you're like, yeah, it is simple, but it's difficult. It's simple enough to follow, which is I want passive range of motion, active range of motion, quad recruitment, normalized gait. I'm obsessed with those for the first 6 weeks or protection phase. Like I don't really care about any other I don't care about clamshells. I don't care about anything else really. Like every exercise I give is to improve these things because there are goals that I want to make sure we achieve, right? And so it's all performance based. So like, as you can see the criteria for the first 2 weeks, I want 0 to 90 degrees. Like that's trouble. That's challenging for some people, right? To get that true 0, but we're working at that. We're doing joint moves, whatever we need to do that. And I want at least one straight leg raise if I can at the end of the second week. Maybe a little lag, but hopefully no lag. And then between 2 and 6 weeks, that's when we really ramp up in terms of really working on that range of motion. And then a lot more confidence with putting weight on the limb. We're getting out of the knee brace eventually, and then we're trying to get off of any type of assistive device. I believe in trying to walk at normal as soon as possible to limit or avoid, to me, bad movement patterns like hip hikes and all those things.
Leon, how many times a week are you seeing patients in this first phase? Let's say their motion is, it's not behind. They're not, dysplastic and hypermobile, but they're normal, right? You got your 90 degrees at 2 weeks. Things are going well. They're fairly compliant. Do you say you stress the very specific things like motion and quad activation and gait. Do you give them a lot of home program and come in once a week to save visits for later? I mean, obviously this depends on insurance coverage also, but what's your preference?
If it's insurance based, if it's insurance, meaning like visits is a problem, or
is it right? We're going to have to apply and so on, right? Just so people kind of we can talk about both,
okay,
right? So like, what would be your ideal if you had no, it wasn't a pro athlete, but you had no real limitations? They had, let's say, 50 visits that they could use, and you can use them at your
If I have 50 visits at my discretion, and they are on schedule, right, and compliant, then I would only have to see them once a week in the early stages, really in the protection stage, like honestly, or if they start walking well, I load them early, right? I start loading them a little earlier, but let's just say, for a safe answer, once a week if they're on schedule. They don't need any manual stuff. They don't need a little overpressure joint moves or anything like that.
Okay. And in terms of all the other, like they say to you, listen, I also want to do upper body, I want to do some core. And obviously that's not the focus of, what rehab is going to do, but what's your coaching of them for that point?
I tell,
when can they start in your thought process? When can they start some of that stuff?
I maximize my time in the protection phase and tolerance phase. Like I don't do a lot of that extra stuff in the beginning. I mean, I feel like reps on whatever we're trying to improve, right? And that's just me. I know a lot of people like to do extra stuff, and I think sometimes just to appease an athlete to think that, so they don't think they're getting out of shape, or vice versa. But me, I don't do a lot of that in the beginning. It's not until really the end of tolerance, probably the beginning of capacity throughout, is when you start rebuilding the whole athlete. That's just me, though. Right? That doesn't.
No, and that's what this is about, right? I mean, the thought is, again, as we said, there's no necessarily wrong answer, but I think the point is, and I think it's a valid one, that you're in the protection phase to lay down the foundation, and the time you have, whether it's once a week, twice, or 3 times a week with your physical therapist, is utilized specifically for those reasons, not to kind of try and get everything else, right? We can certainly, I think you and I have probably spoken to a lot of strength coaches or trainers or whoever that may start working with them at that 3 or 4 week point, but that's not what the focus of PT is.
No, you're absolutely right. I think, and I guess one of the common things I also keep saying is I'm very locked in to what my goals are, right? So performance-based, in order to be performance-based with your rehab, you have to have goals set, and multiple goals set throughout the whole process. And like, if Alex, you came in for the first session, I'm letting you know that I want in 2 weeks X, Y, and Z. And then when we reach those, I'm telling you again what those are. And it's very hard for me to implement anything that I think doesn't get them to their goals right away. I don't know. I'm just trying to be very efficient in that instance.
I think that's right. I agree with that. Okay. do we have another poll coming up? Am I on this? Yeah, we are. Okay, so return to sport mostly looked at time after the injury, after the surgery, or are we looking at other performance metrics? Just to sort of set the stage for the rest of us here.
So you
not
okay?
Not for you. Just the poll. Don't answer.
Okay.
Don't get carried away here. Because I think, the one thing, and I'll just give you there is those outliers, those people that look great at 4 months, the 5 months, right? And it's tough you need to have, and I think this is why it's important to have the objective data. You need to have answers that it's not, sorry, it's just too early. The research says you should wait 9 months, or sorry, it doesn't feel to me like you're ready. As you said, you need to have criteria. So it sounds like most people overwhelmingly would disagree or strongly disagree. But, I think for the, 5 to 10 people that are kind of in the middle or agree that it is time-based, I think that's the conversation to have. Like, as we keep saying, no one's necessarily wrong, because if there was a right answer, we wouldn't have such a high repair rate, right? So I think it's an interesting conversation. So let's keep moving on.
So here's a couple of videos. Oh, I don't think I have access let me see. Oh, because I pulled it up this way. I can't click on them. Let me see.
AV Squad, do we have anything?
Like, I don't think I can.
That's okay. Why don't you talk through it?
What you can see is this. Man, let me see. Let me think of this one. All right, so she was 3 weeks out, able to go full revolutions on the bike, and was off crutches without a brace. No, sorry. She was only in a brace at that time, and then the following week she got rid of the crutches. Got rid of the brace. Sorry. So 3 weeks, able to do full revolutions on the bike. She was able to also walk without a brace while in the clinic, but I had to walk with a brace outside of the clinic, but no crutches. And then the following week, she was able to remove everything. She did really well. She was one of those like outliers. Like, she had great range of motion as well as great stability and strength, and a little bit of fearlessness about it, right? So in the second video, you'll see she has, you can't really see it, but she has a BFR cuff on her right side, and we're really focusing on the quad, a little bit of quad, lower extremity work. It's not so specific to the quad based on what position I have her in, but ultimately a little bit above 90 degrees, not really going too much deeper than that, just based on where she was. But yeah, she was the same way. We did a lot of balance work, a lot of TKEs, extension work for her to try to normalize her gait. And then a lot of weight shifting drills I do early on to get people comfortable with accepting weight when they walk. So, and she is at this stage, I want to say she is maybe 8 weeks out now. All right. And so moving on with their tolerance phase, now 6 weeks, past 6 weeks, I just say let's avoid exercise that are painful and cause increased swelling. I keep it simple in that state. And so that's gonna allow me to be specific to the person, right? As opposed to just we won't do X, Y, and Z, and that rules everyone out. And my focus is I really want 95% of range of motion compared to the uninvolved side by the end of the tolerance phase, preferably the first half of the tolerance phase. So ultimately, I think we talked earlier about tolerance phase really lasting from 6 to 14 weeks ish. So by 10, 11, hopefully 10, I want them to have 95% of their range of motion compared to the other side. Of course, I want them to normalize going up and down stairs in a reciprocal manner, and then normal functional patterns, right? So being able to do a bodyweight squat past parallel symmetrically, step up, step downs. We'll talk about the testing on the other side. Different variations of lunges, lateral, forward, reverse, and then jogging progression. So different types of skips towards the end of that phase, getting them ready for their first jogging episode. So here you can see criteria to pass. I think I always relied on just my video and but I think with the addition of the Delta Force plays by Kinvent, it has really helped me get the objective data that I need in order to see where's their weight being distributed, are they symmetrical. It's just another added bonus for me to say, yes, they passed this, they can move on to the next phase, right? Also, as I mentioned earlier, there's a certain amount of lateral step downs that I would like them to do. In this case, I want them to be able to do 30 straight consecutive. That shows strength, endurance on one limb, a little bit of balance as well. And then I want them to be able to do the forward step down. That's a lot harder, but I still want that on 2 risers without any deviation. The Y balance, I do the Y balance test, and I like them to be about 85% of the uninvolved side. Single leg squat to box. It's a big time one for me. I definitely like that. That's like my checks and balances. If they can, find a way to do these things prior to the single leg squat to box, it all shows up if they can't. If they have a lack of strength, quad strength, or they have compensatory patterns, you'll see it in the single leg squat to box. I like for their trunk angle to be, for the most part, vertical, if not no more than 10, 15 degrees, as opposed to using the hip strategy as they come up. And I use the cue, don't fall through the cloud. So if I'm going to a box, I don't want them to land heavy. Like they should be just tapping and come back up. They got to show me 25 of those. And then the last piece, and this is all through the tolerance phase. So you know how you asked me about like, how am I checking if they're on the right track? What are my checks and balances? Mm-hmm. Obviously, they can meet the first one pretty early, right? Then they move on to they demonstrate greater levels of strength, right? So lateral step down is easier than the forward step down, right? And then the Y balance, those 3 different angles, front, anterior, medial, and then lateral, those are challenging, right? So I want to see, are they using a strategy that is quad dominant as opposed to hip dominant? Are they bending the trunk forward to lean, to reach, or are they bending the knee to reach? So those are the things that I look for as well. And then this lower extremity loaded test, a friend of mine and I came up with this for like a regular assessment. But I was like, you know what? This is actually good for my ACL. Any surgery, lower extremity surgery candidate would be good for this. It would be good for us. So it includes, I use strengthlevel.com and I use their normative value. So they have a beginner. So a beginner is like someone that never really worked out at all. So they have, based on their age, based on their weight, certain percentages for the exercise that you may be interested in, right? And then you have novice, you have intermediate, advanced, and then elite. And so I at this stage, they're not beginner. They should have a certain level of strength, right? They didn't just have surgery. Novice is where I start. And so I'm like, okay, they have to have a certain level of strength, and they have to demonstrate 70% of what Alex would be recommended for based on the strengthlevel.com novice norms. So Alex, if he weighed 160, I'm just making this up, they may say for the forward lunge, which is one of them, he needs to be able to do, I'm making this up, 35 pounds. In each hand, dumbbells, 35 pounds. And I want you to be able, and so I would say, all right, we're going to take 70% of that. And he has to be able to demonstrate the ability to absorb that force, push back up, and do that 12 times. Then the next one is a goblet squat. These are not in order, but I'm just going to list them all. Usually it's double leg first. So it's goblet squat, 70% of what the strength norms is. Then your forward lunge. Then you have dumbbell RDLs. So that's double leg. And then I have them do single leg bridge test where their foot is on a bench. it's a test. Like they got to be able to do 25. So that's a test. That's actually in the study. I can't quote it right offhand. And then I want them to do calf raises, these 25 calf raises, single leg calf raises. Then I'm like, all right, they are able to start jogging. And this is where I want to share. Alex and I, we were debating on terms of like, should they start doing box jumps first? Should they start doing like single leg hops first, demonstrating different things before they start jogging? I think it's a great question for us to ask, right, ourselves as we go forward, just because running is a little bit more dynamic and requires a more force absorption. Doing a box jump, so you jumping to a higher height or depth, is easier on the joint in the knee compared to landing when you're running, right? Like, because that's just all your weight and the depth is the same, right? So that makes sense. But if you were going to ask where would I start that, it would definitely be in tolerance phase. And they wouldn't have to pass the lower extremity loaded test in order to start that. They would have to pass that to start jogging.
Yeah, so I think what's important to sort of note here is that the testing, it really does run the gamut of the entire thing. It's not like you sort of have a test at the end of this phase and you've got to do all of these things before you move on. You've got to start doing this testing well in the early phase of this phase so that you can even perform the lower extremity loaded test, right? I mean, that's a real test. Being able to do 12 loaded lunges, goblet squats, I mean, these are hard things, the double leg RDLs, things like that with real weight, especially for someone that, though they may have started working out, before, or they may have played some rec sports before and they consider themselves, or we would consider them, a recreational athlete, they may not have really been doing loaded squats appropriately or loaded RDLs appropriately before. So there's some learning curve there. So to me, I think this is a significant amount of testing, and the one thing that I would say is you probably have to be confident enough in your process that if they do not pass this, I do not put them in capacity, right? Because you better be sure about that, right? Because to me, you don't have enough phases to sort of cheat it, because like, look, you didn't pass it. That's my number, right? And so even though like I look at it, because I'm a little bit more, just admittedly, a little bit more of that clinical mindset because of how I sort of grew up as a therapist, I'm going to say, look, you've got to be able to do some of this functional stuff, but then I want to see what your quad looks like. And I'll base a lot of things off of that isolated strength, because that's where a lot of that research is. And so even though I may look at it and say, look, I'm just going to play devil's advocate, there's too much functional stuff here and not enough isolated quad strength testing. But the amount of functional stuff you're testing is so, I think, significant that it has to, as we talked about in the beginning, it has to come out in the wash, right? At some point, being able to do 12 reps of lunges with an appropriate weight is going to cause deviation, discomfort, swelling, or something that occurs in that leg if it's not ready. You just can't, because I think one of the big things that's missing, unless you're looking at, true biodex testing, Vail Sport Cord or something, we don't do any kind of real muscle endurance testing. We don't do anything on a fatigue muscle. But I don't know, how long does the low extremity loaded test take? It's got to take.
Yeah, it don't take that long.
Right?
But you're right. Like,
but 10 to 15 minutes of lower extremity working out one after the other is hard. I mean, that's fatiguing, right? So,
but you're right. Like,
if you're not ready,
no, you're absolutely
not ready.
right. You're absolutely right. I think. So you make a good point in a sense where you have to the isolated quad strength is very difficult to do if you don't have like a dynamometer, right? Like if you don't have that, right? Mm-hmm. And so it's interesting that you brought that up,
it has
right?
to be applicable.
For me, when I worked on this guide and these phases and specifically for the ACL, this was before I started using or had the capacity, the ability to use the dynamometer, right? with Kinvent, so the K pull, right? So I didn't have access to the K pull. It's a great tool, right? It's a great tool to give you the isometric data that you need in order to say, if I was to isolate this one muscle and compare it from right to left, what are the true asymmetries in peak force, average force, time for fatigue, and then also like its ability to what's its acceleration like, right? Like how much can they actually, what kind of power can they generate, and how fast can they do it?
Right. What's that rate of
Right,
force
right.
development?
So I think this would still be a great time to add it in. And in fact, if you guys go to my page on Instagram, I did an 8-week assessment with the one of my ACL patients, and the Kinvent. So I used the K pull as a quad measure, right? But I did have her go through all these as well, which was pretty cool to see. There was a certain level of asymmetry for sure. I think maybe 25%, but she's right where I would want her to be. You know what I mean? Like in terms of this is 8 weeks.
Yeah, 8 weeks at 25% is
Right.
pretty
Well,
good.
when I
mean,
did it,
you know,
I can't remember if I did it at, and don't quote me on it. I have to look again, but it was about maybe 25, no more than 30, 32. Like it was 25, 30.
it's fine. I mean, yeah, that's why
Right.
they're at 8
Right.
weeks. That's why they shouldn't be right. It just confirms what you're
Yeah.
testing,
So
right? But I think it's a different way to look at it,
it
right?
is.
It's just you have to be able to, your brain has to be able to share both sides of it to say what's isolation, what's functional. Do the two like kind of complement each other, or are they contradictory?
And that's so far what I've been testing, right? Like this is all a big test, right? I just have like the I just have the ability to do it just because um it's my practice, right? I don't have to answer in a sense. I don't mind taking the blame, the downfall, and so that's the risk, right? But yeah, like I
Mhm.
think it is unique to say that before I had the K pull, this is what I was using, and
Mhm.
and don't you and you mentioned it, it's true. What don't come out in the wash will come out in the rinse. So eventually, down the line, you're gonna have
I
trouble
like
and you're
that.
gonna
That's a good one.
struggle, and that's when I have to
I'm gonna take that.
fall
Yeah.
back and figure out why.
Cool. Okay, and I think you have some examples of some of the stuff you're doing, right?
Yeah,
Intolerance.
but the challenge is I
I'll
can't
make
show
sure
the
the
video.
videos.
I'm sorry
Yeah.
about that, guys. All right. So tolerance, I try to give you the spectrum of tolerance, right? So I have some retro resisted walking. Also, so this is cool. You see, collegiate football player came to me. He was, I want to say about 12, 13 weeks out. And he had already started jogging, but he came to me with pain. And he said, I'm just jogging. I'm not jogging right and stuff like that. So I went and did the step down test. He couldn't pass the step down test, so he wouldn't be jogging in my clinic. But he came over the spring break, and for 2 weeks he worked with me. But he wouldn't be jogging. It's performance based, right? So I had him doing a lot of like single leg isolated work, a little heavier, a lot of eccentric loading with PVC pipes, so he can get that depth, isometric contractions within the range that he struggled with, where he was shaking. Definitely loaded him with a little bit of that, like full on knee extension after 12 weeks, loading him up. So that's a good case here. She at the this was probably like 10 weeks out. We're doing the rower. She's normalizing her pattern, so she was doing walking lunges, single leg squat the box, working on that because she failed that test. Uh, Introducing lunges, heavier weights with deadlifts, that kind of stuff. And then, as you can see, that towards the end of tolerance, we started the process of running or jogging progression. So working doing like backwards, like just backpedaling, backwards jogging, A skips, really working on removing that deviation of that limp when you land, not accepting weight, absorbing correctly. So that's kind of the continuum, as you can see, which is cool that she was 10 weeks out, further along than he was, just due to the fact that he couldn't do the step down test, right? So you just kind of, if your checks and balances are the test. And he wasn't mad at me. He was like, "Yeah, man, I can't," and I'll struggle. As soon as I brought him up, he's like, I struggle with these. So that's why you struggle with running, right, Alex?
Right. All right, so that brings us to our next poll. If we do have, that you put up, if there is swelling with exercise on that tolerance phase, do we go back to protection? Don't answer, Leon. We're doing a poll. See what people sort of think. Like, do we, if you're doing exercises, if they're doing whatever the exercise is that you deem appropriate, you start to have some swelling in the knee. Do we backtrack? And I think this is an answer that certainly, if you want to weigh in on, I think it's important, because I think that happens a lot. And I think what do you do with that as the clinician?
Yeah, you let me know when you want me to fire.
Yeah, all right, fire away. It looks like most people would say, oh, wait a minute. I would say most people would say, no, we don't go back to tolerance phase. I'm sorry, we don't go back to protection phase. But now we get a little bit of maybe we do. Ooh, maybe some people are neutral. All right, go ahead and fire away. What do you think?
Those that said disagree, I agree, right? Unfortunately, that is, to me, that's like panicking, right? It's like, oh, shoot. The knee is going to give you feedback through pain, swelling, tightening, stiffening. And it's our job to figure out why. So sometimes it can be the new movement, the new volume or load, or they just are now. When did you introduce the exercise? Was it during the middle of their workout? Was it at the end of the workout? Now we just have to figure out what are the variables that contributed to it. Do you continue to do that workout or that specific exercise in which you felt caused the swelling? Not immediately, because you need more data. You have to consider, do they not have enough strength? Was it just too much too soon, meaning the number of exercises, the amount of volume? So I think it's a time for reflection more so than just putting them back in protection phase. Definitely do your principles of trying to reduce the swelling, train around pain, but continue to train and figure it out. Giving a good example, a patient came to me, actually the one in the middle here. She said, man, I'm starting to have a little, I was having some knee pain, I think it was from the last time I was here. And I think that's when we did like I think it was the forward step downs, if I'm not mistaken. And so what I did was we loaded her posterior chain that day. So we trained around pain and we focused on hamstring, glute, just heavy, right? Limiting the amount of knee bending and flexion just to reduce irritation just not to add to the irritation. And then when she came back, we focused on the mechanics again. The next session, after we did the posterior chain work, we focused on that forward step down and try to figure out why or when it was painful, or where she felt the discomfort. And from there, we focused on the mechanics in pain-free ranges first for that visit. And then I gave her homework to work on it. So let's improve our ability to do that. Let's improve our tolerance, right? This is why it's a tolerance phase. Like, you didn't tolerate forward step down. So that's why we're not there yet. But how do we get to being able to tolerate forward steps down? So I think, no, we stayed right in tolerance phase and we got out of it pretty quickly. She didn't have a setback at all. Honestly, she just a matter of feedback.
I would agree. Yeah, I would agree. I think regardless of your approach, right? If your methodology, if you're staying true to it, right? Protection phase of protection of the graft and protection of the overall progression, right? If you're beyond that phase, then you probably went to the next phase, to tolerance, or to the 6 to 8 week, or 6 to 10, however you sort of stratify it, because you're confident about what you're doing. And so if the knee, as you said, is giving you feedback, you look at frequency, you look at load, you look at duration of that load and what's happening. And then figure out whether or not how do we adjust it based on this feedback, right? Clearly it's not ready for what we're doing, but going back to, as you said, protection is panic because something is wrong. Now, something could be wrong, right? But most of the time it's not, if we've taken the steps.
Right.
If I'm hearing you correctly. Cool. All right, let's move on.
All right, capacity phase, precautions, really just similar to tolerance in the sense where like avoid exercises that are painful and that can cause increased swelling. We'll be mindful of that, as we just spoke about. And then I don't want to initiate cutting until they have passed the 80%. That should be intermediate. Sorry, not novice, because novice was the run. Should be intermediate. That's my fault. Intermediate strength. So that's a step up. That means you have to demonstrate a certain more strength, but the rep count is lower, so it's 8. Okay, and so that's the major difference there. And our focus is any flexibility deficits. So quad length, the Eli stretch, like when they're on their stomach and stretching, that becomes a little bit more like I'm really making sure that is cleaning up. I'm still sticking with the 2-to-1 ratio quad to posterior chain. Progressively loading those functional patterns that we've already spoke about. Linear running mechanics are clean and they're sprinting. They can sprint, right? That within this capacity phase, you're working on intervals of sprinting. It's almost like I like to use this analogy where, like, if you're a shooter, a basketball shooter, right? You can shoot the ball. You're a very good shooter. Your form doesn't change whether you're close to the basket or further away. Similar to with the running, the jogging, your form doesn't change, right? In terms of how your deviations, your patterns, your biomechanics, they may speed up, but they don't change. Similar and with the running. So I want to make sure that's clean. And then they are accelerating, decelerating linearly without any problem. Stopping on a dime, those kind of things. And then in terms of criteria to pass, this is where we want to see close to 85% of quad strength isometrically using the K-pull. And then our loaded test, I wrote it out here. I didn't write it out last because I ran out of space. But again, we're looking at the same measures, but with heavier weight and load. So the forward lunge, the goblet squat, dumbbell RDL, those things. And then and the calf testing, I always test calves. This one, I can't remember. I know I did it. I do it in novice intolerance as well. But here I probably would also look at that soleus strength. So I would look at more with a bent knee, what that looks like.
Yeah, I would agree. I mean, I think the one, as you alluded to earlier, the one place that we sort of, kind of differ a bit is, do you box jump and do you depth jump and do you, kind of do all of the plyometrics double leg before you do any, like, personally, I'll do a lot of my plyometrics double leg, even ladder all double leg landing prior to doing any single leg linear stuff, because I think it's a load. But again, as you said, if you're doing enough of the testing, if it doesn't come out in the wash, it'll come out in the rinse, right? Like at some point you'll notice that difference and probably hold off regardless of what you're doing. But I think having an approach that's repeatable and you can draw conclusions from is probably the biggest takeaway from regardless of the approach. And having the objective measures, whether your objective measures are functional or your objective measures are isolated to knee extension, flexion, quad hamstring ratio, whatever it is. But I think find your place with objective measures and sort of stick to it. Can you go into a little more about why you put a lot of emphasis on the calf and plantar flexion?
Yeah, like I just feel oftentimes in general, even general population, like calf strength, right? And with calves, with calf, people don't look at it this way, but running is a sequence of many hops, right? Which is basically from knee down, the calf.
Or many falls if I'm the one running.
Or many falls, right?
If I'm the one running.
Sprinting, they're not falling.
I'm running many. You might be many hops.
Or sprinting, they're not many falling, right? They're moving, right? So there's many hops. Right. Oh, either way, you're right. Early on in jogging, many falls, sprinting, many hops, yes. But there's a certain level of calf strength and endurance that I think needs to be considered for the whole chain of that leg, as opposed to just thinking quad dominant. I just believe in it. I really do.
Cool.
All right, so
Cool.
let's see here with the so advanced capacity phase, load them up. Load. Like load the trap bar, load the safety bar, load the functional pattern step downs with weight now. That's when you see just load. But also I really start to initiate a lot of lateral strengthening. So your landmine, lateral lunges. I'll do what I can't think of right offhand, but there's just I'm just very big on, like, before I introduce a plane of motion, I train and progress in that motion as I go. And so if I'm trying to cut now, change the direction, I am going to load it in a pattern form, and then expose them to a plane of motion, let them get comfortable, let them feel it, the nuances of that plane, and then we load it, and then we start to do these different types of deceleration drills. So, like, your snap downs and stuff like that, snap downs without weight, snap downs with weight, medicine balls, stuff like that. Those are my progressions in terms of change of direction. And then
Cool. I think we have a poll coming up now in terms of capacity phase, right? If they're at that, should they reach the capacity phase by the 8th week? I think we've sort of gone over this, but now we're not saying should they graduate from it, but should they go through tolerance phase and getting into those dynamic motions by 8 weeks?
Okay.
Give them a sec here. It's so tricky, right? Because it is so patient dependent. But the overall, like, what's your like somebody comes in off the street, it's, no offense to you, let's say they're me, or you, let's say they're me and they're a recreational athlete, maybe they're more than recreational, but like, they're not a high school, they're not a collegiate athlete. What are you expecting out of that patient? In my head or in your head, like, is 8 weeks a number where you say, okay, I'm going to start loading dynamically at that point, and if you're not there, I'm worried? Or you're saying, doesn't matter, 8 weeks, 10 weeks. Like, if they're saying to you, doc, when am I going to be able to jump again? Right. And how long? Well, capacity. Well, how long is that? Right. So what do you tell them?
I just tell them, I flip it back. I always do. I say, well, can you go up and down stairs without deviation? Can you do 25 single leg squats? Because you remember, like, in order to get the capacity phase, they have to pass this, right? So my novice, they got to do 30 lateral step downs, 15. Like, if they're able to do that, sure.
Yeah, go for it.
Hey, Alex,
but you ain't doing it.
Sure. Like, what do you want to start with? Like, whatever, right?
Right.
I just think that it's very difficult to speed up the ACL process, regardless of who you are. Like, now, granted, there's certain people can take some weeks off. Don't get me wrong. I think so. But in that early phase, you see a lot of people struggle with either range of motion, accepting weight. They still have like that, that I call like a heavy knee, heavy leg when they walk. Like, it just seems bulky, like they're dragging it. Right. It's like, yeah. So I just think those are usually my main focuses. And even those that have been done very well, it'd be hard for me to believe they can pass those things that are required to get the capacity phase.
I think we keep sort of the dead horse that we keep beating is basically you have to have objective measures regardless of what they are and how you implement them. If you say that you are functional based or criteria based, right? Whether time is always a factor, right? No matter what, people work on a schedule, time's a factor. So, but if you have objective measures, then anyone can test your merit, right? Like, am I ready? Well, I don't know. Right. Like you said, can you do these things? If you can, go for it. If you can't, then you're not ready. It's not me. It's not my intuition. These are the tests.
That's right.
Cool. All right, let's keep moving.
All right, so return to sport. People always ask, so when can I go? When can I get back? Right? When can I get back? And if you guys one at a time, it would probably, this is right around that 5.5 to 6 months where people have demonstrated the ability to cut and those things. And so you start doing a little bit more sport specific things, right? So return to sport, like sport specific movements. So this doesn't mean they return to sport. This means I show the criteria necessary to actually,
They're in
right.
the phase.
They enter the return to sport phase. Sorry. So the
Correct. Right.
precautions are, you're really still trying to avoid things that cause pain and swelling. Really monitor those. And so there I put intermediate strength, right? But it should have been on the other one too, in order to pass the capacity phase. But yeah, I just want to make sure that they have demonstrated that strength that we're looking for in regards to, before I start really getting into that cutting, multiple cuts, like hard stops, like those things. And then our focus still want to restore flexibility, and that's when I look at like the hips, I look at the ankle, trunk. I just want it all to be working as one unit. Flexibility, local, and then also their mobility. Because sometimes you start to see that can impact the way they actually move, getting in and out of cuts and so forth. Also, I want to go back just a tad bit. So not a tad bit, but just capacity phase is when I can go back to your question. When will I start doing like core stuff, like all those different things, putting it all together, explosive movements, your cleans, that kind of stuff, your capacity phase, right? And then it also continues in return to sport. I just want to make sure I got back to that question that you asked earlier. And then nothing really changes in terms of still low, just keeping it simple. What are the main movements? Let's get them stronger. And then criteria to pass, less of the loaded assessment because they've demonstrated a certain level of functional strength, right? Now I want to see at an isolated level, are they close to 90 to 95%, right? In order to leave out of or pass the return to sport criteria, where I can say, hey, go play your first game, go back to practice, right? Start ramping up there. People don't understand, once you have passed the return to sport criteria, there's still a ramp up phase. Like practice, you don't do those back to backs, you're not going back and playing the number of minutes that you used to play. Like there's going to be swelling, there's going to be setbacks, like you're going to have it one day. Like it's still a process. But I would definitely want to check out the quad strength with the K pull. I want them to be able to jog a mile. I'm strict. I want them to be able to jog a mile without any limping. Like show me strength, show me endurance, right? You want to get out there, you're going to be running suicides, you're going to be doing all these things, these tests. You got to be able to last, right? At least a mile. Show me you can perform sprint intervals at the fastest, at your top end speed, whatever that is at that particular time, right? Can you sustain it? Are you limping? Accelerate, decelerate, change of direction and cut safely. You've demonstrated those things on a consistent basis. I'm going to use Kinvent force plates for my my depth landing, single leg hops, all those different things to see, okay, visually, what's cool about Kinvent, the force plates now, I think they're adding where you can actually record it. Not just meaning record the video, not just get the data. So that's even better, right? So now I can actually go back and look at what it looked like and compare from, whatever week this is, and right before they're tested for seeing if they can pass the return to sport criteria. So that's pretty cool. And then Y balance should be 95 to basically no deficit. Like I want you to be pretty much even there, able to jump and land symmetrically. You can do that with the Delta force plates as well, but also single leg. I want them to be able to show me the single leg and lateral hop test. I want to see what that looks like from left to right. And if they are a collegiate athlete, I try to go with some of the norms out there. So that I don't want them to, because if you only go from side to side, so left to right, then who's to say, right? Who's to say that other one's not any good? That's any good anymore, right? So,
right.
I would definitely look at more normative values there, and then I think I put April sprint with compensation. Kind of got ahead of myself, but that's what I'm looking for in order for them to start, really for me to feel confident. Like, yeah, go ahead and start integrating yourself back into practice, get some reps in, that kind of stuff.
Great. I mean, I think, like I keep saying, the overall message is have your tests be confident in them and make sure that they build on each other and complement each other. And you can sort of, any patient that walks in, whether they are underperformers or overachievers, can go through your testing, and sub point, the test will tease it out, right? So as you said, I think you can get as involved as you want with a multitude of functional tests. You can get very specific on, isometric knee extension, or you can start getting, more into that patient interaction with the recording the video with the force plate. I mean, I think my question is, if you had to choose, is there a specific couple of tests that you really enjoy seeing someone do? Step down, step up, I think you mentioned single leg box squat, isometric knee extension, force. If there's a couple of things to wrap up, what do you think? Because I think most questions people have is in that 14 weeks and up, that return to sports, 16 weeks, 20 weeks, they come in, they're still not quite there. What are the couple of tests, if you couldn't do this entire battery, what are the couple of tests that you just love and you lean on? That doesn't mean the other ones aren't, but practically you sort of love.
What time frame did you give me? Or are you just saying in general?
Return to sport. No, I'm saying return to sport.
Return to sport,
I'm saying beginning the return to field activities. I'm not going to say sport, because they're really not, like you said, they're reintegrating into sports. They're now getting back to, dynamic field activity.
Okay.
I
know some people don't like the triple hop test. I do, because it shows me how can it repeat. Like, are they landing and able to be explosive again, right? So single and triple hop, both hop tests, in this particular phase, I think are very useful. You truly see what kind of power they have. Are they barely jumping?
Mm-hmm.
Are they landing? Are they not jumping because they can't absorb forces? Why are they so different from left to right? I think the isometric quad strength is also a very good test, because you can't trick the clinician on that one, right? It's a software. You either have it or you don't, and so you got that. In terms of another battery of tests, because some people like, man, I don't do the single leg 25 single leg 25 single leg squat to box until this phase. Then I'm like, well, I already did it, but I would definitely like to see the single leg squat to box. I mean, in this phase, I think it's too late, like, to do that, because of the fact that you're asking people to cut, you're asking people to jump, land, hop. Like, I want you to have a certain amount of strength already for that. But to really just answer that question, and I can have access to whatever I need, then I would say delta force plates. I would say I want an isometric quad strength, and then I want the single leg hop, because I get it all. I get quad strength isolated. I can say, do they have 90 to 95%? There's no other factors. They didn't use their hip, they didn't use their toenail, whatever. Like, they use right.
Just is what it is.
Then
right.
What's their power like? So power is going to tell me strength, as well as how. So power is how fast you can do something, like how explosive and quick you can do something. So you got to have a certain amount of strength in order to generate the force to do it fast, right? And so I want to make sure that I look at the single leg hop and triple hop. So Kinvent, so the quad, the hop, and then sorry not to answer this question the way you may want it, but I want to just see their overall movement efficiency. And so I can do
that's
a
what I
pro
want.
agility test. I can do there's just a number of tests I can do if I have the space to do those things. I'm definitely want to look at those things. I want to see how they're getting in and out of cuts. Are they when they approach a cut, are they getting lower? Are they staying high? Where's their trunk? Like, I want to see how they're moving. So almost like their movement efficiency. Yeah.
The quality of that movement. Great. Awesome. Well, thank you. Listen, I appreciate it. This has been a great, I think, webinar. And I think they'll record it. Thank you everyone so much for joining. I know we ran a little bit late, so I'm really glad that most everyone stayed to tune in. Thank you so much, Dr. Knight, for coming to join us. And we hope to see you again at sometime soon. Join us, be on the lookout next time for the next one that we have. Thanks so much, everybody.
Thank you, guys. I really appreciate it. And I can't wait to do the next one.
Absolutely.
All right.
All right, guys. Thank you.